Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm really privileged to be with Dr. Qais Radaideh. He's a second year general oncology fellow at Creighton University.
Yeah, hi.
Qais, always nice to see you.
Absolutely.
I think we have been doing multiple interviews every time you come here.
Every time, since 2017.
Yeah, exactly.
Right.
Since before your residency and now here.
I was, yeah.
And thanks for your contribution to the conference, presenting cases, and really important. So you presented a new technique for approach for CTO through collaterals. Can you please educate us about it?
Yes. So this case that we have, it's from my mentor Shamas in Davenport, Iowa, Midwest Cardiovascular Research Foundation. So a claudicant patient with extensive history of intervention, endovascular intervention in her extremities, RB class 4. She presents with claudicant symptoms, and we did a CTA of her lower extremities. She had a CTO on the left side at the site of the stent that she had in her SFA, reconstitutes distally. So for her extensive disease, we decided that she needs to be intervened upon to relieve her symptoms. We approached it from the contralateral approach with a regular 6 French sheath, ran the diagnostic. We upgraded the sheath to a destination sheath. And this technique is basically have been reported in Japan in 2017. So obviously CTO and central stenosis, you need an embolic protection. In her case, her flow to the distal popliteal, we couldn't use that to deploy a filter. So we tried to cross the proximal cap with the sheath without using any contrast. We made sure with fluoro that we are in the proper location. You dilate. First of all, you have to aspirate once you're there. Make sure that there is no antegrade flow. You treat the whole CTO segment with angioplasty. We already know from the CTA where it reconstitutes distally, so you try every stage of treatment, ballooning, you aspirate, and you start stenting from the distal up to the proximal with Eluvia stents. And once you reach the proximal edge of where your sheath is, you pull the sheath, and as you pull, you start deploying the stent. And at that point, the antegrade flow has been established, and we got excellent flow to the lower extremity with zero embolization.
And this is a self-expanding stent or balloon expanding?
Eluvia. It's a,
and
the drug-eluting stent.
Yeah, and do you...
Self-expanding.
Self-expanding. And do you... but is there any role for any imaging, intravascular imaging, to see if you are luminal or not?
So we kind of knew we are luminal because she had a pathway of stents there. I mean, she had
you have the
stent, prior stenting in the proximal SFA, distal SFA. So we...
Yeah. How about the proximal cap? How, if you are like subintimal or on the edge of the stent, how do you confirm that?
Excellent.
Is by just a tactile feel, how that sheath is getting through the stent?
Yeah, so she had a very good location for the, this is why this technique was used. Obviously, it would be very challenging in times where you're not giving contrast, how to know where you are and how to know where you treat.
Yeah.
So the origin of the cap of the SFA was at the bifurcation of the profunda and the SFA, and at the edge of the stent.
So you know exactly what it is.
By
and it's big lumen.
And it's a big lumen there. So by fluoro, you kind of confirmed you're in
the stent.
Yeah.
Exactly, yeah. When you say you cross with the wire all the way to the stent.
You cross with the wire, you advance the sheath and the destination.
The size of the wire, I missed that part. 014, 035?
035 guide wire.
Yeah.
That's what assisted to cross the CTO.
Yeah, so you go distal?
Angled glide, yes.
Yeah. And you drive the sheath over that wire.
And you drive the sheath over it, you make sure it passes the proximal CTO. So the CTO blocks the antegrade flow.
Yeah.
So it's like an embolic protection. You treat the whole segment, and as you come back,
deploying a stent.
And make sure you aspirate in every time. And
what's the point of aspirating?
So there's a lot of debris.
Oh, you're sucking out the debris.
And you're sucking out the thrombus and debris. And we know that from
basically thrombectomy, basically.
You're basically doing suction thrombectomy.
Yeah.
It's 30 cc syringe, well sealed.
Okay, interesting. And did you get usually debris from?
Significant debris we got, yeah.
Oh, really?
Almost 30 cc's of.
And that's a 6 French destination sheet.
6 French destination.
So you have enough lumen to degrade.
Exactly.
Awesome. How do you usually, after that, do you have any precautions, any antiplatelet therapy? What's your measure?
So yeah, we know from trials that Xarelto, rivaroxaban has the low dose 2.5. I mean, this is a very vasculopathic patient. In some studies, they even advocate for full anticoagulation. Of course, she was on DAPT for at least 3 months, aspirin and Plavix. She was on cilostazol, which we stopped because we're adding more antiplatelets, and we continued 2.5 Xarelto.
Okay, without that. Well, that's very interesting. I think the most exciting moment when you are finished and you want to take that shot.
Yes.
Because to see if you're going to have flow or zero.
Yeah, we have excellent flow, and we confirmed it with nitro. There was no distal embolization.
Because last thing you want to be like,
definitely.
and there's zero flow.
And there's zero flow.
It means you have what happened.
You wasted a lot of balloons and time.
Exactly. All right.
And you can save. Sometimes embolic protection with a filter can be difficult.
That's true.
Especially with a lot of debris, might
you cannot
even retract the filter.
And we fill it out. Anyway, we're going to fill it with debris anyway.
Yeah.
Well, guys, great case, great technique.
Thank you.
Thank you for, I think the audience enjoyed it for sure, and for the audience there.
Yeah.
Please watch the videos and others on CVI 2022 YouTube channel. This is Chadi Alraies.
Thank you, Shadi.
Guys, thanks so much.
Thank you.